When a patient arriving with severe thoracic trauma rolls through the doors of a hospital, the margin for error drops to zero. Every second wasted is a measurable loss in blood volume or oxygen saturation. This branching logic tree maps out the deadly dozen, 12 specific, life-threatening chest injuries recognized in advanced trauma life support. They are split into two distinct categories based entirely on how fast they kill and how they must be detected. One branch contains the hidden sex. These conditions are potentially fatal, but their mechanisms act slowly enough that clinicians have the time to detect them during a secondary survey using detailed diagnostic testing. The other branch holds the lethal sex. These injuries cause death within minutes. They destroy the body through acute ventilatory failure, obstructive shock, or massive hemorrhage, leaving no time for a slow, methodical workup. Because of that speed, advanced trauma life support mandates a strict rule. Relying on radiological imaging to diagnose any of the lethal six is actively contraindicated. Leaving the trauma bay for an X-ray is a fatal delay. Instead, clinicians are required to identify and mechanically reverse these 6 specific conditions, relying strictly on the primary survey, the ABCDE clinical signs. Survival in thoracic trauma does not depend on the resolution of a hospital in real time. The primary survey begins with A for airway. A complete or partial airway obstruction is the single most immediate threat to a patient's life. Diagnosing an acute obstruction requires listening and looking. The clinical markers include audible stridor, hoarseness, or gurgling, paired with visible intercostal retractions and cyanopsis as the patient starves for oxygen. This 3D cross-section highlights subcutaneous emphysema, dark pockets of air trapped under the skin around the neck. Finding this on a physical exam indicates a severe structural failure, specifically a laryngeal fracture leaking air into the surrounding tissues. Restoring airflow requires immediate, non-invasive mechanical intervention. Clinicians start with the jaw thrust maneuver to physically lift the soft tissues off the back of the throat, immediately followed by suctioning blood or vomit blocking the passage. If basic maneuvers fail to restore breathing, management escalates to manual inline orotracheal intubation, securing a breathing tube while carefully stabilizing the cervical spine. But standard intubation has limits. If massive midface trauma destroys the normal anatomy, passing a tube through the mouth becomes physically impossible. That defines the threshold for immediate surgical intervention. Securing a compromised airway means anticipating failure at every single step. If non-invasive methods cannot establish an airway, the clinician must instantly pivot and cut into the neck to perform a surgical cricothyroidotomy. The B in the primary survey stands for breathing. Here, the primary threat is a tension pneumothorax, representing a catastrophic failure of intrathoracic pressure. The clinical diagnosis rests on unilaterally absent breath sounds, a hyper-resonant drum-like sound, and a physically deviated trachea. This animation shows the hidden pathophysiology. Air continuously leaks into the right pleural space, but cannot escape. The building pressure crushes the right lung and physically pushes the heart, mediastinum, and trachea entirely to the left. As we zoom in on that physical shift, notice how the extreme pressure kinks the vena cava shut. Blood can no longer flow back into the heart. This triggers obstructive shock and severe hypotension. Reversing this requires immediate mechanical decompression. Inserting a large bore 14-gauge angiocath into the 5th intercostal space at the mid-axillary line forcefully vents the trapped air, instantly allowing the heart and vena cava to snap back to their centerline positions. Needle decompression is strictly a temporary bridge. It keeps the patient alive just long enough to place a definitive 28 to 32 French chest tube. This internal pressure crisis contrasts sharply with an open pneumothorax, where an external physical defect in the chest wall creates a highly visible, bubbling wound that sucks air inward. Because the hole in the chest wall offers less resistance than the trachea, atmospheric pressure equilibrates directly with the pleural space. Every time the patient attempts to inhale, air bypasses the lungs entirely, entering through the wound instead. This diagram shows the required treatment, a 3-sided occlusive dressing. It acts as a one-way flutter valve. Air escapes out on the single, untaped side when the patient exhales, but the dressing sucks flat against the skin to seal the wound during inspiration. Taping down that 4th side removes the flutter valve. If air enters the chest cavity but cannot escape out from under the dressing, the open wound converts directly into a fatal tension pneumothorax. Both a tension and open pneumothorax kill by disrupting normal intrathoracic pressure gradients. Survival requires manually venting trapped gas and re-engineering the chest wall's physical seal. Moving to C for circulation, the primary survey isolates the threat of massive hemothorax, blood rapidly filling the chest cavity and causing hypovolemic shock. Clinically differentiating a massive hemothorax from a tension pneumothorax requires precision. Instead of distended neck veins and hyperresonance, a hemothorax presents with entirely flat neck veins and a dull, solid sound to percussion on the affected side. In this scenario, the eFast ultrasound is the only imaging tool permitted during the primary survey. It provides immediate confirmation of dependent fluid pooling at the base of the pleural space. Management runs on two simultaneous tracks: aggressive volume resuscitation using a balanced 1:1:1 ratio of red blood cells, plasma, and platelets, paired with massive drainage via a 28 to 36 French chest tube. This line graph displays the strict quantitative triggers for surgery. If placing the chest tube results in an immediate return of 1,500 milliliters of blood, the patient requires an emergent surgical thoracotomy. The secondary trigger tracks sustained blood loss. If output maintains a steady drainage of greater than 200 milliliters per hour for 2 to 4 consecutive hours, surgical intervention is again mandated. Managing a massive hemothorax is an exercise in fluid mechanics. Inputting blood products must perfectly balance the volume draining out until a surgeon can definitively clamp the source of the bleeding. The respiratory bellows can also fail mechanically. A flail chest occurs when multiple adjacent ribs fracture in more than one place, physically detaching a segment of bone from the rest of the thoracic cage. The defining sign is paradoxical movement. While the intact chest expands normally, the disconnected flail segment sinks inward during inspiration, pulled down by the negative pleural pressure, and then bulges outward during expiration. The visual deformity is obvious, but the lethal mechanism is hidden. The massive trauma to the ribcage causes extreme localized pain. The patient naturally splints their breathing, taking shallow breaths that rapidly induce atelectasis, lung collapse, and severe hypoxemia. Restoring the mechanics of the respiratory bellows requires aggressive pain control. Administering epidural analgesia or intercostal nerve blocks allows the patient to breathe deeply enough to maintain oxygenation without immediate intubation. If flailed chest is a failure of the bellows, cardiac tamponade is the failure of the pump, caused entirely by external restrictive pressure around the heart. The clinical diagnosis rests on Beck's triad: profound hypotension, distinctly distended neck veins, and muffled, distant heart sounds, caused by the insulating layer of fluid filling the pericardial sac. Clinicians will also look for pulsus paradoxus, characterized by a drop in systolic blood pressure of greater than 10 millimeters of mercury, specifically during inspiration. This simulation of an eFast ultrasound confirms the restriction. The distinct black anechoic stripe represents fluid filling the pericardial space. As that fluid builds, the pressure forces the right ventricle to physically collapse under the strain. Rapid fluid administration maintains the cardiac preload just long enough to perform an ultrasound-guided pericardiocentesis, draining the fluid with a needle to relieve the pressure on the heart.